Next, we are going to discuss is the thyroid gland. Remember this thyroid gland, its shape is like butterfly. So it is a butterfly shaped endocrine gland that is located in the neck. And it is located, remember, anterior is trachea and below is the larynx. Now, what is its role? Remember that its role is to regulate metabolism, growth, and development through production of the thyroid hormones that are particularly T3 and T4. T3 is triiodothyronine and T4 is thyroxine. Now the gland, remember, it's highly vascular. That means it has an efficient supply of hormones to the body. Now let us discuss the embryology of the thyroid gland. The thyroid gland, remember, it originates from the median endodermal growth. So this median endodermal growth, that this growth is known as thyroglossal duct. So from the floor of pharynx between the first and second pharyngeal pouches. Now by the sixth intrauterine lies the central column that forms the thyroglossal duct. It is resorbed. The duct bifurcates to form two lobes of the thyroid gland. Remember, a portion of the thyroid gland, it may persist as pyramidal lobe that extends on the isthmus, and it is more found on the left side. Now the thyroid gland, remember, again it develops from the endodermal cells that are located in the floor of pharynx, and the process, it begins with the formation of diverticulum that is known as thyroid diverticulum. As the thyroid diverticulum elongates, it forms the thyroglossal duct. So this duct enlarges to form the thyroid. So this duct will elongate downward, passing in front of developing thyroid bone and thyroid cartilage. Now, what is the contribution of ultimobranchial body? So this structure, it contributes to development of thyroid gland by providing the C cells or the parafollicular cells. So these are responsible for production of the calcitonin, that a hormone that regulates the calcium level in the blood. So the ultimobranchial body, it originates from the fourth pharyngeal pouch and migrates into developing thyroid to form the parafollicular cells. Now remember that thyroid gland, it is located in the anterior neck and it is enclosed by pretracheal fascia. It consists of two lobes. The two lobes are right lobe and the left lobe, the right lobe and the left lobe. These two lobes, they are connected by central isthmus that lies in second, third, and fourth tracheal ring. Remember the weight of typically thyroid gland, it's 20 to 25 grams, that is the weight. Now remember the lobe, there is a pyramidal lobe that extends from the isthmus on the left side and it is connected to hyoid bone by fibrous tissue that is also known as levator glandulae thyroidae. Apart from that, important structure is suspensory ligament of Berry. So this strong condensed connective tissue that secures the thyroid gland to the cricoid cartilage and upper tracheal rings that provide the stability. So suspensory ligament of Berry that would provide the stability. Now vascular supply of thyroid gland, remember it is supplied by superior and inferior thyroid artery, the superior thyroid artery and the inferior thyroid artery. So the superior thyroid artery, it arises from the external carotid artery, whereas the inferior thyroid artery, it arises from this thyrocervical trunk. That is a branch of the subclavian artery. The venous drainage, it is accumulated by superior, middle and inferior thyroid vein that drain into the internal jugular vein. Now the thyroid, we know it produces hormones that are T3 and T4. So these hormones, they are important for regulating the metabolism, heart rate, body temperature, and various bodily function, including the growth and development. Another hormone, calcitonin, remember it is produced by the parafollicular cells. Calcitonin, it helps to regulate the calcium level in the blood by inhibiting the bone resorption. Thyroid gland is responsible to various conditions like overproduction of the thyroid gland or enlargement of the thyroid gland can be due to the iodine deficiency, hyperthyroidism or the hypothyroidism. Overproduction of thyroid hormone is hyperthyroidism, that is known as Graves' disease. So overproduction of thyroid hormone that could lead to symptoms like weight gain, increase heart rate, etc. And hypothyroidism is insufficient production of the thyroid gland. So that results in symptoms like weight gain. So remember, in hypothyroidism there is weight gain. An example is the Hashimoto thyroiditis. Now, what are the fascia? There is the part of the fascia that encloses the thyroid gland is the pretracheal fascia. This fascia, along with the suspensory ligament of this berry, it secures the gland to trachea and provides the stability. Now we know that the thyroid gland, it will move upward during the swallowing as they are tightly connecting to the laryngeal aperture. The arterial supply, we know that it has a high vascular supply. The first is the superior thyroid artery. It is branches of external carotid artery. It enters from the, remember, upper pole of the thyroid gland, and it divides into anterior and posterior branches. Whereas this inferior thyroid artery, it arises from this thyrocervical trunk, that is a branch of subclavian artery. Now remember, the inferior thyroid artery is ligated away from gland in order to avoid damage to the recurrent laryngeal nerve. Other is the thyroid ema artery. So this artery can arise from the brachiocephalic trunk or directly from the arch of aorta. It supplies the lower part of isthmus. Now for the surgical part, you have to remember that due to the anatomical position of the superior thyroid artery and branching pattern, here the ligation is preferred at the upper pole during the thyroid surgery, whereas in inferior thyroid artery, as it has a multiple branches and it is lies close to the right laryngeal nerve, careful dissection must be done in order to avoid damage to the nerve. Apart from that, if there is a presence of thyroid artery, one can expect unexpected bleeding during surgery involving the lower part of the thyroid gland because it is branch of arch of aorta. Now moving to the venous supply, the venous drainage of thyroid gland is the major vein are the superior thyroid vein. So it drains the upper pole of the thyroid gland and follows the path of the superior thyroid artery. Other is the middle thyroid vein. It drains into the lateral part of the thyroid vein and also drain into the internal jugular vein. Whereas the inferior thyroid vein, remember inferior thyroid vein, it forms a plexus of vein rather than a single vein and drain into the lower part of the thyroid gland. Additionally, you would see is Kocher's vein. Remember that for your MCQ. It is rarely found and it is found between the middle and inferior thyroid vein. And its awareness is important in order to one can expect is unexpected bleeding. So proper identification and management of these veins are important in order to prevent excessive bleeding. Coming to the anatomy of the thyroid gland, so we know it consists of, on microscope you would see is lobules that are lined by cuboidal epithelial cells. So these cells would produce thyroid hormone and these are the colloid. So center consists of colloid. The lymphatic drainage, the subscapular lymph node, it drains into pretracheal and prelaryngeal nodes. The lymph from these nodes drain into the lower deep cervical nodes. Now human body, you know that it requires 100 to 200 microgram, that is 0.1 milligram of iodine per day for optimal thyroid function. What are the source of iodine? That could be milk, dairy products, seafood, especially the fish. Coming to the steps that are involved in thyroid production, the first step it involves the active transport of iodine from the bloodstream into the thyroid follicle cells. So that is facilitated by sodium iodine symport located on the cell membrane of the thyrophytes. Compounds like thiocyanates and percolates, they can block this process, preventing iodine from entering. The second process is oxidation of iodide to iodine. So once inside the thyrocyte, iodide is oxidized to iodine. Third step is formation of iodotyrosine. So this oxidized iodine would bind to amino acid tyrosine, that is component of protein thyroglobin. So that this iodination, it produces two products, mono iodotyrosine and diiodotyrosine. So these undergo coupling reaction to form the thyroid hormone. And remember, carbimazole can block this coupling stage and reduce the synthesis of T3 and T4 hormone. Now these thyroid hormones, they are stored in follicles, follicular lumen of the thyroid gland within the colloid. So when needed, the thyroglobin, it will undergo proteolysis, protein breakdown, and T3, T4, they are released. Now T3, remember, it acts quickly within a few hours, and it is more active form of the thyroid. Now let us discuss about the thyroid function test. The first is the serum T3. Well, the normal serum T3 level is 1.5 to 3.5 nanomole per liter. Now remember, which one is more potent, T3 or T4? Remember, T3 is more potent than T4 and has a shorter life. Majority of T3, remember, it is produced by conversion of T4 in various tissue. Remember, the free T3, it is used in diagnosis of, especially in diagnosing early hyperthyroidism, especially in the pregnancy, where T4 and T3 level rise earlier. So the free T3, T4 level here rise earlier than the total T4, T3 level. The next is serum T4. The normal level is 55 to 150 mole per liter. So T4 is the predominant hormone that is produced by thyroid in normal state. The TSH level normal is, remember, 0.3 to 5 international unit per ml of plasma. So the elevated TSH indicates primary hypothyroidism, and low TSH suggests hyperthyroidism. Other test is a serum thyroglobin. So it is produced only by the thyroid tissue. The level should be low after total thyroidectomy, and the level may increase in thyroiditis, Graves' disease, or toxic multinodular goiter. Other is thyroid antibody levels. So detection of antibodies such as in diseases like autoimmune disorders like Hashimoto thyroiditis, Graves' disease could be useful in diagnosing the autoimmune thyroid diseases. Now let us discuss about the complication that can occur Now let us discuss the patient complaints while history taking. The patient will complain of swelling. The long-standing thyroid swelling often indicates benign condition like multinodular or colloidal goiter. The rapid growth, short duration with the rapid growth that indicates malignancy, such as the anaplastic carcinoma. The rate of growth, benign diseases are usually slow growing. A rapid growth may indicate malignancy. Example is follicular carcinoma. The patient may complain of dyspnea, that is difficulty in breathing. The cause could be small goiter with rapid growth. Anaplastic carcinoma that is infiltrating the trachea. So the dyspnea, remember, difficulty in breathing, it can be caused by a compression of trachea, particularly in retrosternal goiter or the rapid growth malignancy. The patient may complain of difficult swelling, less common because the esophagus, we know it is located posterior to the thyroid gland. The patient may also complain hoarseness of voice that indicates the possible malignancy affecting the recurrent laryngeal nerve. There may be symptom of hyperthyroidism, toxicity, CNS with eye defect, tremors, sweating, heat intolerance, etc. Eye symptoms may include the patient may complain of exophthalmos, that is the protruding eye that is seen in Graves' disease, cardiovascular systems, palpitations, arrhythmia, congestive heart failure, increased bowel movement, irregular menstrual cycle that could patient complain of. The patient in the hypothyroidism may complain of lethargy. He may feel tired. There may be deposition of fat. Remember, in hypothyroidism there is weight gain. The patient may complain of husky voice. Thickened vocal cord from myxedema can lead to characteristic voice change. The patient may complain of intolerance to cold. Sensitivity to cold temperature occur due to reduced metabolic rate. So you can check is the duration, progress and rate of growth. Investigate symptoms like dyspnea, dysphagia, hoarseness of voice. You can inspect the swelling, the extent of swelling, like the swelling it is observed generally in the front of neck. It will extend from, remember, this swelling is generally extend from the suprasternal notch to the thyroid cartilage. Now, the thyroid swelling may have different surface texture. Like they have a soft texture that may indicate condition like puberty, goiter or Graves' disease. They have irregular texture that is seen in carcinoma of thyroid, or they may have nodular texture like seen in multinodular goiter. The thyroid swelling generally moves upward with the deglutition. We know the thyroid, it is surrounded by the pretracheal fascia. Which forms a ligament that is known as ligament of Barry. So this ligament is attached above to the cricoid cartilage. So during swallowing, this cricoid cartilage moves upward So that causes the thyroid gland to move with it. So if there is a restricted movement during swallowing, that may indicate a malignancy with fixation to the trachea, retrosternal goiter that could occur. Other test you can do is protrusion of tongue test. So this test is done to detect the thyroglossal cyst. When patient protrudes his tongue, remember the thyroglossal cyst, it may move upward due to its connection with the tongue base. Other test is swallowing test. During swallowing, the entire larynx and hard bone they are elevated along with the thyroid cartilage due to action of various muscles including suprahyoid. So this ligament of Barry, it connects the thyroid to cricoid cartilage that causes thyroid gland to move upward with the larynx. Now, apart from that, you can do is palpitation, confirm the size, shape, surface characteristic and border of the swelling. So you can check for the consistency. Soft consistency seen in Graves' disease, colloid goiter, firm seen in multinodular goiter, hard consistency seen in carcinoma. Apart from that, you can confirm the movement with the deglutition. Other test is you can do is chin test. In case of multinodular goiter, when both lobes are enlarged, the patient is asked to bend the chin downward against resistance. So that produces contraction of both sternocleidomastoid and making the gland less prominent. Other methods, other indicative methods could be other methods are Kreil's method that helps to appreciate the nodularity better. The examiner he will place the thumb over suspected area of the nodule and ask the patient to swallow. Other method to test is Lahaye's method that is used to palpate the posterior aspect of thyroid gland by pushing the gland to one side. Which method is used in obese patient? It's Pizzillo method. It is helpful in obese patient with a short neck. The patient other method is Kocher's method. Compression on the lateral lobes, it produces stridor that may indicate the tracheal swelling. And it is seen in conditions like multinodular goiter or the carcinoma. Remember, in solitary nodule, the trachea, it may be deviated to opposite side. But in case of multinodular goiter, the tracheal deviation may not occur due to the symmetrical enlargement. In a large multinodular goiter, you will see the enlarged thyroid gland may push the carotid artery laterally. So pulsation of common carotid artery may be felt in posterior triangle of neck. Sometimes the carcinoma of the thyroid, it may engulf the carotid sheath. The pulsation of common carotid artery that may be absent due to compression or invasion of the tumor. So absence of carotid artery pulsation, it's known as Barry sign positive. Remember, despite the absence of this carotid artery pulsation, the superficial temporal artery pulsation still may be felt normally, as the arterial lumen it is not narrowed in this condition. Other is the osculation. You can esculate over the upper pole of the thyroid gland. As the superior thyroid artery, we know that sub-branch of external carotid artery is more superficial than the inferior thyroid artery. You can check for the thrill, any vibratory sensation, brute, abnormal sound that may be observed in a toxic goiter that indicates increased blood flow. You can check for the central nervous system and eye sign. Like in case of Graves' disease, you will see exophthalmos. That means the eyeballs, they will be bulging. So examine the cardiovascular system, examine the skeletal system, rule out metastasis, especially to bone that may occur in the thyroid carcinoma. Now the goiter, it can be simple goiter. That can be due to the puberty, termed as puberty goiter. Here you would see is enlargement of the thyroid gland during puberty due to increased hormone activity. Other could be colloid goiter, that is known as iodine deficiency goiter. So that here the enlargement of the thyroid gland, it occurs due to the iodine deficiency. So that is characterized by formation of colloid filled follicles within the thyroid gland. Other type is multinodular goiter. Here you will see there would be enlargement of the thyroid gland. Along with that, you will see multiple nodules. The second type is a toxic goiter. Example is the Graves' disease. So Graves' disease, it is an autoimmune disorder that causes diffuse enlargement of the thyroid gland, and it is related with hyperthyroidism, and it is associated with, remember, auto antibodies. Other you can see is the secondary thyrotoxicosis that occur in multinodular goiter. Other type is toxic nodule that a single autonomously functioning nodule that can cause hyperthyroidism. It may occur with the nodular goiter, or it act as a solitary toxic adenoma. The third type is the neoplastic. The third type is the neoplastic goiter that can be benign adenoma, also known as follicular adenoma. It's known cancerous tumor that arise from the follicular cells. It can be the malignant tumors. It can be there could be papillary carcinoma. It's the most common thyroid cancer that is usually slow growing. Other can be follicular carcinoma. It occurs more commonly area with iodine deficiency. The poorly differentiated carcinoma is anaplastic carcinoma that is highly aggressive and rapid growing. Those arising from the parafollicular cell is medullary carcinoma. It arises from the C cells and secrete calcitonin. Arising from lymphatic tissue is non-Hodgkin type. The other type is thyroiditis, that could be granulomatous thyroiditis. So here you will see granulomatous infiltration. Autoimmune thyroiditis, that is also known as Hashimoto thyroiditis. Other cause could be riddle thyroiditis. It is a rare fibrosing disorder of the thyroid gland. Other rare cause of goiter could be acute bacterial thyroiditis, thyroid cyst, etc. So let us discuss first is the multinodular goiter. So here you would see is presence of multiple nodules within the thyroid gland, and it is more common in females due to the hormonal factors. So it occurs in girls at puberty or during the pregnancy when the metabolic demands they are high and thyroid production hormone, its T3, T4, they are normal. So it is often asymptomatic, but it may cause difficulty in swelling or breathing if the goiter is larger in size. You will see palpable thyroid nodules along with the enlargement of the thyroid gland. So you can do is ultrasound. You can take ultrasound of the thyroid gland to determine the size and characteristic of nodule. The thyroid function test, they are generally normal and it may shine off euthyroidism. Management is observation. Thyroxine may be given to suppress the TSH secretion that can help to reduce the goiter size. The large other thing that you can use is radioactive iodine therapy. So that is used to shrink goiter, particularly in case of hyperfunctioning nodule. The complication that you can see is there can be difficult swallowing, breathing, or hoarseness of the voice. Remember, multinodular goiter, they generally have a good prognosis if they are managed properly. Now remember the table. So this is about the pathogenesis of multinodular goiter. The initiating factors could be puberty. Remember, the hormone changes during puberty can contribute to development of goiter. Genetic defect. Remember, some individuals may have genetic predisposition that affect the thyroid gland. Iodine deficiency. Remember, iodine deficiency, lack of iodine in diet can lead to decreased production of T3, T4. Goitrogens. Certain substance can interfere with the thyroid function and contribute to the goiter formation. Now the mechanism, low level of T3 and T4 that can result from the iodine deficiency. The body responds to low level of thyroid hormone by increasing the TSH production. So elevated TSH stimulates the thyroid gland to produce more thyroid that lead to goiter hyperplasia and the goiter formation. So over time, this hyperplasia can become uneven, leading to area of necrosis. That can cause area of necrosis and area of the active growth. So some multinodular goiter may develop malignancy over the time. After several years, some multinodular goiter may become overactive that lead to excessive thyroid hormone production, that is hyperthyroidism. Now, what are the complications of multinodular goiter? Over time, nodules in the thyroid can develop calcification that can be visible on the X-ray or ultrasound. So sudden hemorrhage in the nodule that can cause difficult breathing due to compression of the nearby structures. Now, what are the coming to the management of the multinodular goiter? Now let us discuss the management of the multinodular goiter. So one you can do is the complete CBC, routine urine examination, and postprandial blood sugar. So that would help you to assess the general health of the patient and conditions like diabetic mellitus, etc., or the the urine culture, or these are important. Second is you can take is X-ray of the neck. That that will help you to get the size of the goiter, check for the compression of the trachea, and look for any calcification. Along with that, you can do is flexible laryngoscopy. That would help you to evaluate the vocal cord mobility and factors that are important before the surgical procedure to prevent damage to any recurrent laryngeal nerve. Apart from that, ultrasonography can be done out. High frequency ultrasound, it is effective in getting the thyroid nodules and detecting the malignancy. Apart from that, FNAC can be done in order to diagnose any malignancy. CT scan, when there are large nodule retrosternal extension, you can do is the CT scan. Now the treatment part, remember the treatment part is a subtotal thyroidectomy, removal of the parts of the thyroid lobes. So here the parts of thyroid lobes are removed, leaving small amount of tissue near the tracheoesophageal groove in order to protect the recurrent laryngeal nerve. Or total thyroidectomy can be done, complete removal of thyroid gland, that is often preferred, that in order to minimize the risks such as recurrent laryngeal nerve or hypocalcemia. So in total thyroidectomy there is no chances of reoccurrence and it avoids the resurgery. Medically, how can you manage the situation is by giving thyroxine. In case of small nodules, that would suppress the thyroid stimulating hormone post-operatively. So this diagram represents the management approach for the multinodular goiter. Remember in the initial presentation, these multinodular goiter, they are asymptomatic and detected incidentally. So you have to manage, observe the nodules as they may regress over time. Patient education is important. You can prescribe this medicine, that is levothyroxine. This altroxine is a levothyroxine that can be given 0.1 to 0.2 milligram per day to suppress the TSH and reduce the nodule size. If there is no improvement, then surgery can be planned out. Now, what are the indications for surgery? When there is the multinodular goiter, it presents with the pressure symptoms. There is enlarged thyroid causing difficulty in swallowing, breathing, or compressive if there are any compressive symptoms, we can plan out the surgery part. Subtotal thyroidectomy preserves some thyroid tissue that avoid the permanent hypothyroidism, reduces the risk of recurrent laryngeal nerve paralysis as compared to the total thyroidectomy. So here there is lower incidence of reoccurrence. Third procedure is the Dunhill procedure. In that, total lobectomy is done on one side and subtotal removal on the other side. So it is indicated if the one lobe is predominantly involved, we remove it. It preserves more thyroid tissue than total thyroidectomy and that is why it reduces the risk of hypothyroidism. Next we are moving to is the retrosternal goiter. So retrosternal goiter, it is a condition where the multinodular goiter develops in the neck and it extends behind the sternum into the mediastinum. So factor could be if patient has short neck, obesity, so that could be the reason, or it can arise from ectopic thyroid tissue. Now types could be, remember, substernal, when the lower border of gland is behind the sternum, intrathoracic. Here the thyroid is not visible in the neck and it is diagnosed by radioiodine scan. The third is plunging goiter. So here the lower border is seen in neck during the cough. That occurs due to increased intrathoracic pressure. So the treatment is surgical excision through the neck incision. So here surgical excision is the treatment of choice. No radioiodine therapy is given. So remember, in case of retrosternal goiter, timely diagnosis and appropriate management, they are important. Why? In order to relieve the symptom and in order to prevent any complication. The next is the toxic goiter. Or term we use is thyrotoxicosis. So thyrotoxicosis, it is a condition in which there is increased level of thyroid hormone that affect the multiple body system. What could be the cause of thyrotoxicosis? It could be either primary thyrotoxicosis, example is the Graves' disease. Remember the Graves' disease, it's also known as exophthalmic goiter. Now remember, it is an autoimmune disorder. Here the antibodies, they will stimulate the thyroid to produce excess hormones, and that leads to goiter and hyperthyroidism. So here you will see diffuse goiter. There would be enlargement of entire thyroid gland due to activity, and there would be that is the Graves' disease. Other cause of secondary thyrotoxicosis could be multinodular goiter, where multiple nodules in thyroid, they produce excess hormone, or other cause is solitary nodule, toxic nodule. So that means a single nodule in the thyroid that function independently of TSH regulation, that lead to hypertrophy, increase in the size and number of the gland, causing tertiary thyrotoxicosis. Other cause of thyrotoxicosis could be jod-based phenomena. What is that? Remember, for your entrance exam, it is iodine induced thyrotoxicosis. So when iodine is given for hyperplastic endemic goiter that leads to excess thyroid hormone production. Other cause could be malignant goiter or neonatal thyrotoxicosis that occurs in babies born to mother with the thyrotoxicosis due to the transplacental transfer of thyroid stimulating hormone. Now, other cause could be drug-induced thyrotoxicosis, like medications that can cause thyrotoxicosis is amiodarone that contains iodine that can cause induced thyrotoxicosis. Now, patient with the thyrotoxicosis would represent clinical features. First of all, he would show weight loss that occurs due to increased appetite. So, patient has a weight loss despite the increased appetite. There is heat intolerance, excess sweating, palpitations, tachycardia, tremor, nervousness, irritability, anxiety, muscle weakness, exophthalmos, that is protrusion of eyeball in the Graves' disease. You can do is thyroid function test. They are elevated. T4, T3 levels are elevated. The presence of thyroid antiglobulin in the Graves' disease indicates the presence of Graves' disease. Radioactive iodine uptake test, thyroid ultrasound, CT scan, MRI, that would all help you to confirm about the diagnosis. But now, what are the treatment anti-thyroid drugs that you can give is, remember, you can give is methimazole, or remember propylthiouracil that would reduce the thyroid hormone production. Apart from that, you can give is beta blockers if patient is suffering from signs like palpitation, tremors. Radioactive iodine therapy that can be given to destroy the overactive thyroid tissue, or surgery could be performed either partial or total in case of large goiter. In Graves' disease, you can give is immunosuppressive therapy or provide treatment for exophthalmos. So, regular follow-up and monitoring of thyroid function test, avoidance of excess iodine intake, that is important in thyrotoxicosis.